for joining us. I'm going to get things started for us today. My name is Emmy Betts, and I serve as the Deputy Director for the Injury and Violence Prevention Center here at the University of Colorado Anschutz Medical Campus. Today's presentation is part of our monthly Research to Practice webinar series, where we present topics in injury and violence prevention. So before I introduce today's speakers, I want to cover a few logistics. First is that this session will be recorded and we will share the video link with anyone who's registered. You can also find past webinars online at our center's homepage, and we'll put that link in the chat. For the audience, please put any questions into the Q&A box. We're hoping to have time for a Q&A session at the end. So please put them, again, in the Q&A box, preferably not in the chat box. The next thing I wanted to share is that we hope you'll mark your calendars for the rest of our webinars. In 2021, we'll be doing them each month on the second Tuesday of the month at noon Mountain Time. So please feel free to bring your lunch and join us for various topics in injury and violence prevention. I'm really excited for next month's session when my group and legal experts will be presenting on our experiences thus far with the so-called red flag law or extreme risk protection order in Colorado. And later this spring, we'll be covering falls as well as opioid use disorders. So we hope that you will join us. And after today, if you're excited to keep the conversation going around hospital-based violence intervention programs, please join us tomorrow, Wednesday, for an informal discussion group at 4 p.m. We have not shared that link publicly, but you are all welcome to attend. If you think you might be interested, please email either Lucia or me, and we'll put our emails in the chat box. So now, on to today. It is my great pleasure to introduce today's speakers. Our session today will focus on aligning programmatic and research goals in hospital-based violence intervention programs. And our speakers are from the brand new At-Risk Intervention and Mentoring Program, or AIM program, here at the University of Colorado Hospital. We know that programmatic and research goals in intervention programs are often viewed as distinct and separate, but understanding how programmatic and research goals both complement and enhance each other, I think can really lead to common purpose and efficiencies, with the opportunity then to create generalizable knowledge across programming and really improve outcomes for all stakeholders. So we have three speakers today. I'm going to introduce them all now and then turn the show over to them. So Dr. Catherine Velopoulos is an associate professor of surgery here at the University of Colorado. She's a former EMT turned trauma surgeon, and she's on call today, so we hope that we actually get to keep her for the full hour. She's a health services researcher who focuses on violence prevention, access to care, and disparities in care. She's worked closely with Dr. Katie Bakes from Denver Health in bringing the Denver Health's AIM program over to University Hospital, and she now directs the program here. Lori Lovedale is a public health educator who played a key role in helping to advocate for and secure funding to expand AIM over to University of Colorado. She has over 20 years of experience in program development, implementation, and evaluation around safety and injury prevention programs, including working with local health departments and fire departments. She's worked on all kinds of topics from statewide prescription drug abuse prevention and awareness, distracted driving for youth and adults, fall prevention, and vehicle and bicycle safety. And she has extensive experience managing multiple statewide prevention grants to implement programming. So we're really lucky to have her here at the University of Colorado Hospital. And then third, but not least, is Anna Cleveland, who is a program evaluator for the AIM program at Denver Health and the University of Colorado Hospital. She's worked as a trauma social worker at the bedside at various hospitals in Maryland, and she developed the first trauma social work position at University of Maryland, Prince George's Hospital Center. Trauma social work positions provide counseling services and case management to survivors of trauma and violence. Anna has experience with program development, implementation, and evaluation of hospital-based violence intervention programs. And her current research and evaluation focus is on client-centered outcome measures and understanding the effectiveness of HVIPs, particularly from the perspectives of staff and clients. So we are really so thrilled to have the three of them here to kick off our 2021 season. And I am now going to turn it over to you. Thank you.
Fantastic. Well, we are super excited to be able to be here to present on this program. And we have such a great team of people that have really helped make this happen and continue to make it happen. I just like to acknowledge that, because as we know with any prevention programs, it's, important that we have, a good team of people kind of working together. So my part is I'm going to talk a little bit about what the program is and kind of how we got it going here. So the AIM program at UCH is really, it stands for At-Risk Intervention and Mentoring. And it's a program it's hospital-based violence intervention program that really identifies patients that are at risk of repeat violent injury, and then works to link them to hospital and community-based resources that really address that underlying risk factor for violence. The AIM is an expansion of the program at Denver Health. So we use evidence-based and trauma-informed approach to care for survivors of violent injury. So
Lori, can I jump in real quick? Anna, could you just switch the display settings so that people can see the slides a little bigger? You're doing the presenter view right now. Thanks.
So Anna, just go up to the top. That middle column you should be able to switch. There you go.
Is that better? Oh,
there you go.
Perfect.
Okay.
Great. Thank you. So you can go to the next slide.
Okay.
So the goals of the AIM program is really to promote healing from trauma, to reduce retaliation, re-injury, and arrest, and to advocate for needed change. Next slide, please. So through this program, and again, like I said, it's an expansion of Denver Health's program, the AIM program over there, but we utilize culturally competent outreach workers. So these outreach workers really work to intervene with patients and their families in the emergency department and also on inpatient floors after they sustain some type of intentional violent injury. So it could be a gunshot wound, it could be a stabbing, it could be an assault. And they really work with those patients to build these trusting relationships, provide that culturally sensitive trauma-informed care to these patients. During that visit, they may speak with patients about their injury just to try to get a little more information around it. They may address any safety concerns that the patient has or maybe the family might have. If there are any retaliation issues that they might have to address immediately. They work to facilitate follow-up, medical follow-up and other types of follow-up, and then really work to connect this patient with any kind of hospital or community-based resources that the patient may be identified or that the outreach workers maybe have identified with the patient. Next slide, please. And then what's really unique about this program, go back to the previous slide.
Sorry.
It's okay. Is that it continues to follow patients and families long-term. So they're really ensuring that they're keeping that individual connected with resources, and they're really supporting them in that healing and recovery process. So, once a patient gets out of the hospital, once they're discharged, the outreach workers will continue to follow them and continue to work with them. So it could be 6 months, it could be a year, it could be more than that. But they'll work with them on goals that this individual might have, but just to continue to help them out, really. And I think that's what's so powerful about the program, is to really offer those wraparound services. So this could be a variety of things. It could be mentorship. Again, it could be safety planning with the patient or the family. Maybe that patient has identified that they want more job skills training. So it could be linking them with those. It could be mental health and substance abuse treatment and getting them linked with that type of care. It could be referrals to primary care, or making sure that the patient follows through with their medical follow-up. It could be support groups. Really, it's working with that patient to identify what their needs are and trying to link them to resources in the community to address those needs. So next slide, please. So I want to talk a little bit about our process and how we really work to get the funding to get this program going. So we all know that data speaks, and that data is really a driver behind good programs. And so we really started looking at the data that was available to us. So state health department data, we looked at City of Aurora data, we looked at our trauma registry and emergency department data, and we looked over, it over a number of years. And what we found is, of course, is that we were really seeing this increase in intentional violent. So next slide, please. So then we really had to think about, okay, so we want to get this program up and running. We know, about the program at Denver Health and how they run. We are aware of other programs throughout the country. Who are our stakeholders? Who would benefit from having this program in the community? And really kind of identified, obviously our hospital would be interested and invested in this program, the City of Aurora, as well as the community. So GRASP, the Gang Rescue and Support Project, already invested in this program at Denver Health. And we actually contract with GRASP to hire the outreach workers. So they're a part of that organization. So community also having a big investment and also really considered, we think, one of the stakeholders around that. Next slide, please. So knowing that, our process is that we really started with our hospital, and we started with approaching our chief operations officer. And again, using that local data that we had pulled together and the hospital data, and approaching it from that point to show what an issue it was in our community and for our patients. And luckily he was very supportive and really encouraged us to also talk to the City of Aurora about investing in the program as well and funding this program at 50%. At that point in time, he did commit from a hospital standpoint to fund the program, 50% of the program for the 2-year period. And that's what we had asked for, is to really kind of pilot this for 2 years. From there, we worked with our government relations person to really link us with the city. So he was able to get us linked with the deputy city manager and representatives from police and fire. So we presented to those individuals a number of times. There was a kind of a change in who the deputy city manager was, so we had to kind of start things over again. But numerous presentations to those individuals, and really focusing on some of these things you see on the slide. Talking about violence as a public health issue. Really pointing out how the trauma center has a really unique role in risk reduction to address this issue. Again, showing local data, of course, which is important. Highlighting the societal cost of violence, especially in our community. Highlighting successful programs throughout the country is important. And then a real key was to bring representatives from GRASP to support our efforts and to have them speak in support of the program, to showcase what has worked, to showcase the hard work that they've done over the years in the community, and how those partnerships can really bring about a good program. And so it was really important to have all those partners involved in this process to really kind of showcase what we could do. The city did approve to move the funding request forward, which we were pretty excited about. And then if you could move to the next slide. On June 1st of 2020, the memorandum of understanding that we had created was approved by Aurora City Council. So very exciting time for us, especially during COVID, because we didn't really know, was that going to affect whether we would get funding or we could even move things forward. So you can imagine we were pretty excited when things did continue to move forward, and we knew that we were going to have the support, the funding support of the program that we needed. So next slide, please. So now we really needed to talk about our stakeholders again. We knew that we were going to get this program up and running. We had a great model from Denver Health, but we needed to think about now, what do our stakeholders want to see? You know, because as we know, putting evaluation in place at the beginning of a program is so very important. So thinking about, you know, what do our stakeholders want to see and what kind of evaluation measures do we need to put into place right from the beginning? And thinking about the different stakeholders. So the hospital, you know, what are they interested in? Are they most interested in a linkage to primary care? Are they more interested in follow-up visits or a safety plan? Thinking about City of Aurora, were they more interested in job skills training and employment, school engagement or recidivism? Were those kind of their things? With the community, was it housing to ensure that you know, patients, residents of their community had stable housing? Or was it to increase protective factors or looking at life skills training? You know, we had to consider all of those pieces. And the hospital might also be interested in recidivism or school engagement or life skills training. But we had to think about all of those pieces. And it may be different, their goals might be different, but you can see actually, you know, everything really complements itself well. But thinking about what our stakeholders wanted to see from the get-go was really important to help us determine those evaluation measures that we needed to put in place from the get-go. And on that note, I am going to transition it to Dr. Velopoulos to talk about kind of how we move forward with our next steps.
Thank you, Laurie. That was a great introduction to what we're talking about. And, you know, this whole point about what the stakeholders are wanting and expecting is really important for just being able to move a program forward. But there is an important part of research here as far as creating generalizable knowledge. And, you know, what's happened a lot with programming, especially anything that involves what's considered any type of social programming, is sort of despite this definition that it's a systematic application of scientific methods to improve the outcomes of the program, there is often a very heavy emphasis on what the local and regional stakeholders want, which is appropriate, but it needs to move beyond that. It's often seen as focused on the program itself and not the individuals, although understanding from the individual standpoint is what really helps us with the program. Research, of course, is sort of, you know, this investigation or experimentation. It's aimed at discovery. The important part is really the practical application and that generalizable knowledge. But especially when we're talking about this type of programming with vulnerable populations, there's been a history of unethical practices, particularly in these communities. And so it's become somewhat of a dirty word. And so there's been a move in some circles to leave these things separate. But the reality is you're looking forward to what your stakeholders are wanting and then ultimately how you can help other programs globally. The information that you get from the research side of it really informs the program evaluation. And so ideally you set all of this up at the same time as far as your goals of what kind of knowledge you're trying to gain and what you're trying to do with it. Next slide. And so there should really be a move towards putting these together, program evaluation / research, which is really a goal of this Department of Justice grant. So a lot of funders are recognizing that knowledge needs to not stay at the local level, but be disseminated. And so Anna will be talking a little bit more about how that is happening in the context of the DOJ grant that we're involved with. I think the CDC agrees with me when you go to the website and look at their steps of program evaluation. The last step is sharing lessons learned, and that's the important thing here. And I think it becomes critical in having these conversations around program evaluation, particularly dealing with vulnerable populations, that everyone understands that we're not experimenting on people, we're not doing research for the sake of research, but that what we're calling research, that we're redeeming the term, so to speak, that we're making research a way to share lessons and give a voice to people who normally wouldn't have a voice. Next slide. And so this is just, you don't have to know the details of this, but there are really good models for evaluation and iterative evaluation in the context of research. This is a precede proceed model. And if you look at it, you'll notice it's a cycle. And so this is something that happens continuously. So you have your formative evaluation for your program, which is really involving the research that you're doing for needs assessment and determining what things need to be set up. And then that goes through a summative evaluation, which becomes more formative evaluation for the next iteration. So this is something that's been in practice for a long time. Next slide. And so when you look at this programming, so this is a conceptual model sort of looking at the intersection of how policy, economics, and behavior work in these situations. And so this is one that I had made around violence prevention and intervention. And you can see the model that we're using with the wraparound program with our case management by outreach workers can really address a lot of these issues. And this is where it's important that we set things up to do the kind of prospective evaluation and research that we need to do to create the data that then can inform policy. Because at the level that we're talking about, it's hard to enact change at a greater level and to disseminate that knowledge. Next slide. But this data that we have speaks to policy. Next slide. And this is important because evaluation and research really informs advocacy. And if you remember back to Laurie's earlier slide, one of the goals of our program is advocacy. So it's to take the lessons that we've learned, it's to advocate for continuing programs, for new iterations, and to help other programs. And ultimately, that doesn't just give information to other programs, but it can inform policy at a higher level. And that's where it becomes very powerful. Next slide.
Thank you, Dr. Velopoulos. And that leads me into talking about giving you an overview of what the evaluation we've been doing with the at-risk intervention and mentoring program at Denver Health, and how this all got started and how this now has expanded over to University of Colorado Hospital. Like Dr. Velopoulos mentioned, this grant is funded through the Department of Justice, the Office of Victim Services, and they are funding the evaluation project to complete a prospective longitudinal study and evaluation of AIMS effectiveness. The name of our demonstration project is called Advancing Hospital-Based Victim Services. We are one of 8 sites on this grant, so there are other programs across the country that are involved in this grant with us. And the goal really was to support evidence-based models, practices, and policies to improve those partnerships between victim services field and hospitals and other medical facilities to increase support for crime victims. So really a lot of victims of any type of violence, it could be human trafficking, domestic violence, intentional violent injuries. The entry point for a lot of those patients are coming into the hospital. So this grant really wanted these programs to be able to enhance those services, provide some evidence-based outcomes to better services for them through the hospital. So we were lucky enough to have technical assistance provided through this grant through the Health Alliance of Violence Intervention. And that is our national network organization where all the programs are part of a network of hospital-based violence intervention programs. It's a great organization. To look at their website, they have a lot of great resources. They provide technical assistance to new hospital-based violence intervention programs. And so they ensure that we have the resources we need through this grant. They make sure that we're meeting our goals and objectives through this grant so that we are successful with our project. So just to give you a little overview of our evaluation plan and design, it's a process outcome-based evaluation. So we're not only looking at outcomes, but also just the process of how things are run through the program. We are using a mixed method approach, combining quantitative and qualitative data analysis. And then we have several measures that we are measuring: client-centered outcomes, individual outcomes, implementation outcomes, and service outcomes. And really they all complement each other, but we wanted to be able to, pull from multiple data sources to really do a data analysis to really show the impact of the program. And just to highlight, we're really focusing on client-centered outcome measures, really to capture those unique experiences of our program participants and staff, not just focusing on the program as a whole, but really like taking in the perspectives of the clients and the staff that, do this work, and to be able to better serve them and learn from them what their experiences are like, so that, we can generalize this knowledge to other programs and what works. And this just gives you sort of a picture describing kind of what our model is for looking at the different measures that I just described. Outcome measures are assessed by a summative evaluation within the design and implementation framework. And then the summative evaluation then is used to incorporate data next into iteration of the program. While this is occurring, a formative evaluation is prospectively done. Really, AIM at Denver Health has been in existence for a long time. So, that's the summative evaluation. And then that helps when we expand to another hospital doing more of the formative evaluation. So this just kind of gives you what kind of outcomes we are looking at, and they do, and that way we can really do a broader evaluation of the program. And then this just, some points to address how program evaluation and research really just complement each other. This is what you can do with it. They provide evidence-based outcomes and recommendations for other hospital-based violence intervention programs. You can create general knowledge to inform effective program models just for other programs within our network that want to get programs started similar. You can understand the impact of the value of the program from the staff and the clients. You can improve your process and serve your clients better. It helps with program sustainability and cost benefit analysis. And then luckily with this grant and me starting as the evaluator, we've been able to expand our HVIP program to University of Colorado Hospital. So this is how they both kind of complement each other. When you do a programmatic evaluation, you're just evaluating the intervention that's already being done to kind of bring some general knowledge to other programs. And just lessons learned through this process as an evaluator. I started in January 2020. I was a year into the grant had already started. So that's, by the time I got hired, that's when I started. But really the most important points I think I took away from it, and I have learned along the way, because this is a new position for me, is really just engage your program staff and other major stakeholders in the design and implementation of the program evaluation, making sure everyone has a voice in the process, what measurements you use, getting to know your stakeholders and your staff, like establishing relationships. So it kind of takes that bias around doing research and evaluation, and you just make it more of a collaborative process with the staff, and just integrating it into your evaluation and research into your programmatic activities. Like some things that I've done is just being involved in their staff meetings, doing interviews with the outreach workers to kind of learn about their process and how they perceive the program and what recommendations they need, because I think they're the experts in this process in doing this work. So that concludes my presentation. I did want to share a video with everyone. It is a video that was done by the Office of Victim Services, supporting male survivors of violence. They did an evaluation. They had a demonstration project with 12 other sites, and they had put a video together showing how service providers can interact with male survivors of violence, and they use their evaluation findings and they put it into a video just to kind of show you some more innovative ways of how you can show your evaluation findings. So let me get that video up here. And we will send this out to the group as well. So you guys, let's see. Okay.
Not surprised to see another shooting in this part of town. Dude's got a roll of cash in his pocket. Probably caught up in some bad stuff.
This guy's been shot 3 times. And he had a stolen bottle of pills in his pocket. Who knows what's in his system?
All nurses to the nurses station.
I get so tired of seeing this. I wish these guys cared more about themselves. If he makes it, he'll be back on the streets and probably back here in 6 months.
Wonder what his story is. I was packing up, getting ready to leave for my spring semester of college. My mom gave me some cash to take back to school. I took it and went to hang out with my homies for the night. My grandma asked me to stop at the pharmacy and pick up her prescription since it was on the way. I was walking to my homie's house when I heard gunshots. I felt a sting, but it took me a second to realize that I was shot. I'd been shot 3 times. Next thing I know, I'm waking up handcuffed to a hospital bed. I was unconscious for 2 weeks. I lost one of my kidneys, my lower intestine, and my spleen. The doctors didn't know if I was going to walk again. And on top of that, I was under arrest and I wasn't allowed to see my family.
What happened to Ron happens all too often to boys and men of color. Research indicates that racial and ethnic minorities are overestimated to be responsible for crime and to be more prone to violence. This is a result of several factors, including our country's history of racist policies, individual unconscious biases, racial bias in media portrayal of crime, and racial disparities in the legal system. Because of the ways in which boys and young men of color have been dehumanized by society at large, effective service provisions requires a culturally responsive and trauma-informed approach. As a service provider, you can support the healing of boys and men who are survivors of violence. You can see them through a different lens, one that accurately reflects their lives and histories. The Supporting Male Survivors of Violence Demonstration Initiative was a 5-year effort to help service provider organizations educate and expand the provision of effective, culturally appropriate, trauma-informed services to boys and men harmed by violence. RTI served as the national evaluator of these programs. This video highlights some of the results of the evaluation and is meant to be a resource for service providers to effectively support male survivors of violence and trauma. In interviews conducted with program staff, RTI learned that one important cultural change that needs to happen in order to effectively provide support is to shift from the idea of men causing violence to seeing men as survivors of violence who need resources and assistance. One staff member discussed how some people have trouble making this shift.
Some people just don't get it. One woman said, "Why are we investing in kids who are committing crimes?" The whole idea of their trauma went right past her and straight to they're criminals. Anyone can be a victim of crime. When someone causes harm, that harm is associated with harm that was done to them.
The reality is, boys and men of color can be victims of violence even if they have caused harm to others. They can also be victims without a history of causing any harm to others. When individuals and agencies adopt this point of view, the door to positive change opens. The Supporting Male Survivors of Violence sites also noted that trauma is often a common shared experience.
What we know is, in the communities where we work, everybody is impacted by trauma just by their environmental factors.
When service providers began to reframe the way they saw the individual, they found they also needed to redefine what was meant by violence and trauma.
Violence is not just what you think about in movies. Food insecurity is violence. When you're homeless, When you don't have a steady place to stay, that's an act of violence.
Trauma is not necessarily associated with one large event. It could be the trauma of your childhood. It could be the years of instability and violence surrounding you.
A lot of these men don't even know they've experienced trauma because it has been so normal for them. Seeing somebody shot is traumatic, but what if you've seen several people shot?
And if they don't even realize they've experienced trauma, how do they know to ask for help? This is where service providers have an opportunity to step in and make a difference.
You can step back for a moment and recognize that the work doesn't have to be within our walls. There are people out there who need the service, and if it means us going to where they are to provide the service, then the job's done.
When you redefine violence and trauma and truly understand how it exists in the communities you serve, the real change can begin. It's important to remember that male survivors of violence may have been let down by public servants in the past. Earning trust is crucial, and many sites hire staff with shared experience to help facilitate a foundation of trust.
If someone who is actively or formerly gang involved gets shot, realistically, your messenger needs to be someone they can connect with, someone they understand, who's saying, "This has made a difference in my life, and I think it could make a difference in yours."
And once that trust has been established, it's important to stay completely engaged so you don't lose it. To be an effective service provider means being consistent and available.
It's not a big or glamorous ask. Just do what you say you're going to do. That's the most important piece. If you say you're going to call tomorrow night at 9, make sure you call that person tomorrow night, because you only have one opportunity with this group of folks.
Changing perspectives and reframing the story allows people to see survivors and the worlds they come from with more empathy and compassion. By applying a racial equity lens to your work, you will be able to see the truth of a person's experience, take action, offer support, and create positive change in our communities.
While I was still in the hospital, I met Kevin. Kevin had also been shot about 2 years before. While we were talking, he told me about how getting shot caused him to have nightmares. I told him I was feeling really anxious. My chest hurt all the time, and I felt like I couldn't breathe. He told me there were services available to help guys like us, like a support group. After I got out of the hospital, I joined the group and was able to talk with other guys who had similar experiences. It let me know I wasn't alone. After a lot of therapy and determination, I was able to walk again, and I went back to college to finish my degree. I don't think I would have been able to do it if it wasn't for the support of my mom and the guys in that group.
So yeah, this video, that was the video we wanted to share with you. They had presented that at the HVIP conference that they do every year. And it was great to see that, because I actually used to be on that grant when I was working in Maryland and DC. So it's really fascinating to see how they took those interviews, that qualitative data, and made it into a video to show, portray their findings. So.
Wonderful. Thank you guys so much. Are you ready to move on to sort of Q&A time?
Yes.
Good. Thank you so much. And there's already a question, and absolutely, yes, we are going to send out the link to that video. Thank you for ending with that. I think it's such an, not just an important topic to kind of portray, but also really interesting to think about how you take research findings and don't just publish the academic papers, but really think about making something that is meaningful for those kind of out in the field. So thank you all. For the attendees, please put your questions in the Q&A box, anything you want to know. I am gonna take a moderator privilege to ask one question, just because I know we have some folks who are on the call locally, and I know that many of them are probably itching to know, how do we get involved? How do we refer patients? Can you give us kind of a a short update on kind of where we're at with that, and how people either can refer patients or maybe volunteer or get involved if they're interested?
Yeah, so right now we actually went live as far as starting to take clients at the beginning of December. What I will say right now is we are only taking people from within the hospital, that we hope eventually to have the capacity to be taking community referrals, outpatient referrals, et cetera. Right now we have funding for 2 outreach workers. So for anyone who actually is working in the hospital, the way that it's working now is we have developed a close relationship with kind of all the players, including ED social work. And when someone comes in injured, the outreach workers get the pages as well. So whichever one is on call, and they wait usually about 30 minutes to make sure the situation has sort of died down. They then call the ED social worker, who gives them an idea of when they should come in. So if there are situations they need to diffuse immediately, or if the patient is ready to talk, then they'll have them come in immediately. Otherwise, they'll see them otherwise. But from within the hospital, it's now a consult. So if you go to the orders, you can just start typing in hospital for hospital violence intervention program, and it pops up. So you can just put in a consult like you would to social work or to the forensic nurse examiners, and we're keeping track of that as well. So right now, we're keeping it to a little bit narrower population, but hope to in the future be able to have capacity to take more, because over the Denver Health Program, they now take other referrals from within the hospital, even if they didn't come in injured at the time, and then some community referrals as well.
Great, thank you. There's a question in the chat box on the same topic from one of our EM residents. So I think the answer for now is connecting through the ED social workers, probably the easiest way for us, but it's really wonderful.
And to answer a little bit, I'm sorry, a little bit more of that question. So they are available 24 hours a day. Because we only have 2 of them, they don't have set hours in the ED, but one of them, if you go to Amion, one or the other of them will be listed. But they're also engaging closely with social work, and the charge is in the ED. So 24-hour coverage, yes.
That's really wonderful. Thank you. Another question I had, Lori, thank you for at the beginning kind of talking about how you got things up and running. I think, funding for anything in injury is always hard. And certainly these kinds of violence prevention programs, I think, can be difficult because they're so complicated, even just sort of the outcomes that you're looking at, as Anna was talking about as well. I hate to ask this question already, but in terms of sustainability, is the hope that that there can be continued funding from both kind of Aurora as well as like hospital or private foundations, or is this something that you're hoping to move towards more grant funding from national sources, or can someone write you a check if they're on this webinar and they want to give you a lot of money?
Please.
Yeah, we're not going to say no to a check. So yeah. Well, so I think, we've looked at a number of different options, and again, just thinking about kind of the evaluation and research, that's another piece of why we want to get good information, as Anna talked about, is just sustainability of the program. I think we would love to see the hospital and the city of Aurora continue funding it, but we also know that, we will be continuing to look for grant funding as well to support our efforts to keep the program going. So I'm anticipating it's probably going to be a mixture of them. Dr. Velopoulos, do you want to say any more about that?
Yeah, so I'm already working on other areas of funding to carry forward. Now, part of our discussion and sort of agreement with the city of Aurora, and the reason we asked for 2 years of funding instead of 1, was that I wanted to be able to actually show them some of the meaningful outcomes and show them they're, of course, very interested in cost savings. And so being able to do cost utility analysis is really important, but being able to show some of these other outcomes as far as what's happening on the police and EMS side of things. But the anticipation is that if we can show at least cost neutrality, that they would be willing to continue funding further into the future. And that happens to be sort of a discussion with the hospital as well. I will say that I want to make sure that our funding source stays fairly diversified. Some of the lessons we've learned from talking to a lot of other programs is that you have any one stakeholder who has a majority claim to what you're doing. They start to dictate how the program is run, and that may not always work the best for the participants or for our programmatic goals. And so I'm already, looking at different sources of funding. I'm looking at some grant funding right now. I've been working with our philanthropic office and the people that we have through the Department of Surgery. And so it's definitely something that you have to look at from that standpoint. But that's why the research side of it becomes very important, because when you're trying to get funding, it's one thing to say that we had this program and we did these things, and unfortunately people look at the data that has been published in the literature as being more valid than maybe white papers or stakeholder reports. And so part of why it's important to understand how research fits into this is so that we're thinking about all the questions that people are going to ask from the beginning. And so it's not that we have to call things research, but we have to understand that to move things forward, to be sustainable, to put the data out there that gives credibility to maintaining these programs. Having the American College of Surgeons has been discussing whether or not to make these types of programs a requirement for level 1 trauma certification. And we can't do that without data. Part of the push from the Department of Justice, OVC grants, is they were getting a lot of good data from programs, but none of that was being put together in what we would call research, and thus not being disseminated into the literature, and recognizing that needed to happen for these programs to gain momentum and for us to have a body of evidence that we could refer to. That's why in this last round, so these grants have been going on for some time. It was in this last round of proposals that they stipulated that you had to have an outside researcher, and they used the word researcher to help with the evaluation, so that there could be that generalizable knowledge. And so there's the recognition of that. And so to get to, I saw, one of the questions in the Q&A talking about the Affordable Care Act and how we make this a part of sort of what our call is as hospitals. That's absolutely what we need to do. I think we need to think of all those research questions and all the things that can move us forward as we're doing it. I do think from just a logistics standpoint, you want to have done all of this and made this all a part of your program, and all of the questions a part of your program, so that when you go to do what's called the quote research, you can just refer back and say, this is a program that already exists. This is already what we're doing. We're not proposing a new intervention for our research. We are just proposing looking back at it in a systematic way. And that gets you into a lot less difficulty when you're talking about IRBs. And so some of it's really semantics, but that's why this all becomes important in that context.
And I think to further that point too, we thought about some of those things before we decided on how we were going to go about asking for funding, and specifically decided on the 2 years, because it did come up during the city council. They asked, well, why 2 years versus 1? And knowing that we needed to be able to, show the amount of data we wanted, that we were able to speak to that and to show them, this is why we're asking for the 2 years, because this is what we want to be able to show you. So kind of thinking that out ahead of time and having that plan, I think was really important to be able to speak to it.
Wonderful, thank you. I think this whole discussion around, is it research, is it evaluation, how are they similar or different in the semantics is so interesting and really so important to think about. Right, we define outcomes and how we really engage communities in identifying those outcomes, sort of in the realm of community-based participatory research and so forth. And for folks at the university, there are some great resources related to CBPR type research if you're interested. There's a specific question in the Q&A about the age restrictions for the program and kind of what the thought is. Is there going to be space for the under 18 population? And I'd be curious related to that, do you have a long-term plan to try to collaborate with Children's for the youth that they see?
Yes, I can. So right now we will take anyone 14 and up. So anybody that we are allowed to care for at the hospital can be in the program. And we're setting that up just off the bat. When we go back to talk about looking at those outcomes, especially in a research standpoint, we can talk, that gives us some leverage as far as these are patients we're already taking care of. We just want to talk about it. But it will be all patients that can stay on our service, and that's 14 and up by our hospital rules. we have in the past talked about collaborations with children. And then I had a conversation a couple of days ago with Eric Siegel. We're working on how we're going to move that forward and what would be in place. Ideally, if we could get one more outreach worker, then all three of our outreach workers could cover both campuses. And so I think that's a goal probably in the next year to expand to being able to help with that as well.
All right, so I'm just going to ask, is the outreach worker, is the barrier finding the right person or having the funding to find that person?
The funding.
Okay, so if anyone has money.
Yeah, and I've been talking with the dean of the School of Nursing, who's very interested in this as well. And so there are a lot of people on campus interested in ways we can find the funding. I will say that this is very hard work. The outreach worker positions are very hard work. In the last round of applications, when we put out the call for the applications for this, we got like 125 applications, I believe. And it was very hard to narrow it down to like the first 30 people that we then kind of sent a questionnaire and narrowed that down. So we actually had a lot of people who were qualified and good for this. We have someone that we really want to hire as soon as we can find some other funding. So that funding is the issue, and a huge part of this program is going to be getting ongoing sustainable funding.
So, and kind of related to that, Catherine, you touched on what a hard job it is. I'm curious, Anna, if you can comment a little bit from your background in sort of bedside social work as well. I mean, I imagine this kind of work for an individual can be hard in terms of reliving their own trauma and so forth. And I'm putting you a little on the spot, but do you have thoughts on sort of what it means to support the program staff, or what you've seen work in other places, or how you support the outreach workers in sort of processing what they're doing?
Yeah, no, definitely. I mean, it's definitely doing the line of work. It affects you, and I think it is important for staff to support each other. One of the ways too is just like really engaging with each other, having like time to process your cases, activities outside of work that are, tailored to help with your wellness. I think what I've seen in other programs as well, and things that I've done in my work as well. When I worked in a hospital-based violence intervention program in Maryland when we were a new program. And what was nice is that we were all part of this grant, but we had other trauma centers with us. And so we, in the Washington, DC area, so all the sites, we would get together and kind of support each other in that line of work, because we knew we like could relate to each other and what we were doing. So I think really just connecting with the people that you work with, and even with AIM, they're a very close-knit team, and they do, put on different wellness activities and try to do that so that they do take care of themselves, because it is can be very tiring and hard work on the staff. So,
and it's especially with all the events going on, this past summer and so forth, it's been very difficult for people. And Michelle McDaniel, who is the program manager over at the Denver Health program, actually has engaged somebody to meet with the staff on a regular basis to go through and process some of that. I think that's a huge part. And some of our evaluation so far has been interviews with the outreach workers over there themselves. And this came up quite a bit. And so part of the program goals are not just addressing the client needs, but addressing the needs of everyone who's involved in the care, and particularly the outreach workers. And one of our outreach workers, he just started with our program, but he was part of the Aurora extension of GRASP. And so he's been working with AGRIP in that area for a while now, and is from the community, and recently experienced an event where, he was working with a couple of young men, and someone was trying to come after the young men that were in his car and shot up his car while his child was in the car with him as well. And that was a very difficult thing for him to have to process. And I think we have to realize that this kind of work has a lot of implications for everyone involved in it. And while they find it very rewarding, we have to be very careful that we're addressing all of those needs as well.
Thank you. We're almost at the close, so before I turn it back to you all for last thoughts, I want to just let our attendees know as a reminder, we're going to continue this discussion tomorrow in a sort of less formal setting. If you're interested in joining, please email me or Lucia for the link. That's at 4 p.m. Mountain on Wednesday. We're having another violence-related webinar actually this Thursday in sort of the words we use in talking about violence and firearm injury. With continuing some of the themes of this. So if you're interested, the link to register is in the chat as well. And then we will be sending out the recording of today's session as well as the link to that wonderful video that you showed. Maybe we'll just turn it back to you all for parting thoughts. And we've talked a lot about funding, I know, but other than that, if you had a sort of wish list or a magic wand for 2021 for your program, what would you want?
I think our biggest wish is to just have this become a process where the outreach workers are very engaged in the process of deciding what it's important to talk about. Because the biggest thing, I do health services research, so I'm already kind of thinking about these things, but the important knowledge that we need to get out of these programs, because to this point, most of the evaluation and research around it talks about recidivism, which is important. But the really important thing is to, I think, bring into the literature, particularly when we're talking about the emergency medicine or surgery literature, is bringing the voices of this into it. And so my hope is that we're able to do that kind of evaluation and research that we want to around the actual voices of the outreach workers and the participants in the program, and that we do that in a really responsible way that makes people actually feel heard. And so my hope is that that's indeed what we're able to do.
I hope we can have them have you all back with the outreach workers at some point in the future. Anna, yes. Laurie, any wish list or parting thoughts?
I'd probably just piggyback off what Catherine had said, in being involved in the evaluation, just really being able to portray, the stories of the clients and the outreach workers, just engaging more of that, generalizable knowledge to put that out there. And because I know they work very hard and, put a lot of work into this. So just giving them a voice, in that, so.
And I think from my end is just really getting this program integrated in our hospital and just making sure that we reach all the patients that we can and that they have the most positive experience they can at our hospital and with our outreach workers.
Wonderful. Well, thank you all. There's a parting note from a participant for people who are interested, is to sort of look at the HVIPs, which is the national organization that does a lot of this work, as well as the annual Healing Justice Alliance conference, which I think is their annual meeting. Mm-hmm. But thank you all today for taking your time out. Catherine, I'm so glad you did not get called to the ER while you were with us. And thank you to all the attendees for joining today. We hope to see you tomorrow and at future webinars. Thanks a lot. Bye.
Thanks, everyone.
Thank you so much.